Hello, this is Dr. Gary Siskin, and today I'm going to be speaking about mechanical embolic agents. This is the first of two lectures on mechanical embolic agents, which are all part of a larger lecture series on embolization. I do like to stress the importance of being able to classify different embolic agents. In this particular case, I like to look at mechanical agents, which are coils and plugs, etc., compared to flow-directed agents such as particulate embolics, microspheres, and liquids and gels. In this case, we're going to be talking about mechanical agents. We use mechanical agents for a number of different indications, including trauma, visceral aneurysms, preoperatively before endovascular repair of an aneurysm, or even before radioembolization at times. We use them to treat GI bleeding. We use them in cases of AV fistulas when they're not maturing appropriately. And we even have venous indications such as pelvic venous disease and varicoceles. Back in the day, and I am old enough to say that, if we wanted to use a mechanical agent, we generally were only able to select a pushable coil. There were no other options. The good news is that this has definitely changed. Today, we have pushable and detachable coils, we have microcoils, we have fibered coils or hydrogel coils. There are a lot of different tools that are available to us to accomplish the clinical goals in the setting of those indications I listed earlier. So let's talk first about coil construction and the characteristics that can help us determine which coils we may want to choose in a given situation. Coils are typically made with biocompatible metals, and these include nitinol, platinum, iridium, and tungsten. Alloys of these metals may also be used. Remember, each of these metals has a different strength, which is referred to as the modulus of rigidity or shear modulus. When we look at how coils are configured, we usually talk about them in terms of three structures. The primary structure is the stock wire, which is made of a metal, or one of the metals that I mentioned earlier. The secondary structure consists of the stock wire wound around a mandrel. This is known as the primary wind of the coil, and it's this diameter, or D2 on the diagram, that determines how we group coils, as either a microcoil or a standard angiographic coil. The tertiary structure consists of the secondary structure shaped into any number of tertiary configurations, such as spherical, or helical, or complex, etc. So there is a formula that helps determine the stiffness of the coil. This formula relates to the stiffness of a spring, and no, you don't really have to know this formula, but I like to include it in this lecture because it shows which factors are important in helping to determine the stiffness of a coil. First and foremost is the diameter of the stock wire. This is the most important determinant of coil stiffness, as you can see by the fact that it's raised to the fourth power in this formula. The shear modulus, or the rigidity of the stock wire, is also important. It's linearly related to the stiffness of the coil, and this depends on the metal or the alloy used. Now, there are two factors which are inversely related to the stiffness of a coil. The first is the diameter of the secondary structure, and the second is the number of wraps per unit distance when forming the secondary structure or the primary wind. You can just imagine that a larger N, or more wraps per unit distance, is achieved when the stock wire is wrapped very tightly around the mandrel. So that's the internal configuration of the coil. What about the external features that we can see? How do they play a role in how coils behave? Well, the first and most obvious feature are fibers. Several different coils have different fiber types, like Dacron, nylon, or PGLA. And in addition, they may have different concentrations of these fibers. Some coils don't have any fibers at all. The reason why coils have fibers is to increase their thrombogenicity. This study performed benchtop testing and showed that fibered coils with either nylon or PGLA were more thrombogenic than non-fibered coils, which validates the reason why fibers are there in the first place. It also showed that nylon fibers were more thrombogenic than PGLA fibers. Scott Traratola also looked at this. He evaluated the effects of nylon fibers on the performance of platinum coils in animals with follow-up at 1 and 3 months. he found that fibred coils were more thrombogenic than non-fibred coils, and in fact, fewer fibred coils were required to achieve occlusion. With that said, and we'll come back to this, similar recanalization was seen with both types of coils. Fibers can also impact the stiffness of a coil, its pushability, and its packability. So coils with fewer fibers tend to be softer and they tend to pack better, and coils with more fibers tend to be stiffer. There are also non-fibred coils that rely on hydrogel to help with the occlusion. The Azure coil has a layer of hydrogel incorporated onto the surface of the coil, and upon contact with blood, the hydrogel expands to 3 to 4 times its original size. And the thought is that the space-occupying nature of the expanded hydrogel helps promote vessel occlusion. When looking at this in different papers, it was shown early on that more fibred coils are required to occlude target vessels than hydrogel coils, but embolization with hydrogel-coated coils takes more time. Another study by Dunlop showed that fibred coils, especially those with Dacron fibers, have an improved embolization efficacy over hydrogel coils as measured by embolization time and unit length of coil. Finally, Folan did 2 studies and found that when comparing fibers and hydrogel, there's no difference in the number of coils used, the time to occlusion, and the inflammatory response. However, they did show that there was less thrombus seen with hydrogel-coated coils, which confirmed the role of hydrogel expansion in vessel occlusion. They also showed that more recanalization is seen with fibred coils, which is likely due to lysis of thrombus. So it seems fair to say, based on the data, that when comparing hydrogel-coated coils to fibred coils, that fibred coils may have an advantage causing acute occlusion, but there may be less recanalization with hydrogel-coated coils. Cost might then have a role in coil selection, since these coils tend to be more expensive than others. So let's shift our focus now to coil delivery, and let's focus on looking at pushable and detachable coils. Pushable coils are pushed through a delivery catheter with a guide wire or dedicated coil pusher. Importantly, they're not attached to the pusher wire, so once they enter the delivery catheter, they either must be deployed or the catheter needs to be removed. It's common to use the back end of a guide wire to introduce a pushable coil into a catheter and to then flip the wire around and use the front end of the wire to advance it through the catheter into the target vessel. One of the nice things about pushable coils is that they can also be delivered with a saline flush once the coil is loaded into the catheter. This is a quick way to deliver multiple coils, especially in more emergent situations. But just remember that coil deployment is much more unpredictable using this technique, so it probably shouldn't be done for the first coil or the last coil being placed. So let's think about the following situations. What if the catheter is not quite where you want it to be, or the coil that you just loaded into the catheter is not the right size, which you realize before or after you start to deploy it? Well, the fact is that these are exactly the moments that go away with the use of detachable coils. With a detachable coil, the pusher used to advance the coil through the catheter is attached to the coil, and therefore must be detached by some mechanism in order to release the coil into the target vessel. This affords a great deal of control because you can reposition or remove the coil before it's detached and permanently deployed. The thing to remember is that these are much more expensive than pushable coils. Another important part of coil delivery is the catheter that you're using to deliver the coil. I think this is the most underrated part of an embolization procedure. You have to remember that the different coils require different catheters for delivery, and this means that our ability to use a particular coil will often be determined by our ability to get the necessary delivery catheter where it needs to go. When we classify different coils into 2 groups, it's based on the delivery catheter that's required to get the coil there. So 018 coils require a delivery catheter with an 018 inner diameter. The actual diameter of these coils is usually between 010 and 014. 035 coils require a delivery catheter with an 035 inner diameter, or a standard angiographic catheter. The actual diameter of these coils tends to be 020 to 024. And if you try to deliver a coil through a catheter with a larger inner diameter than recommended, then the coil may start to form within the catheter, and that can cause it to get stuck. So there are a few different techniques to think about when deploying coils. The one that I think most people use more often is the scaffold technique, and this makes use of framing and filling coils. This is what a framing coil may look like. It's kind of spread out over a longer segment of the vessel being embolized, with purposeful creation of spaces within the different loops of the coil. Generally speaking, detachable coils do a good job serving as framing coils. And then the next step is to create a filling coil, or some coils which are placed in between the loops of the framing coil in order to get a more complete occlusion. And this can be done with either pushable or detachable coils. So in other words, you deploy your framing coil, and then you begin to gradually fill it in with multiple pushable or detachable coils until you get a tight coil pack like this. Another technique that's been described is the anchor technique. This is typically used when there's concern about coil migration in a high-flow vessel, because it can stabilize the coil mass that's being created. So the way this is done is you look at a side branch arising from the target vessel, and you use that side branch to anchor a coil in place before embolizing the target vessel. So you'd put a catheter in that side branch that you're seeing in this diagram, and you would deploy the coil initially in the side branch, and then basically pull the end of the coil into the target vessel. And then once that's securely in place, you can put a number of other coils, either pushable or detachable, until you get the coil pack that you're looking for and the vessel occlusion that you want to achieve. The final technique I want to discuss is something that I call the push technique. And this technique can be used when the goal is to embolize a parent vessel and a side branch, but you're encountering difficulty when trying to catheterize that side branch. In this case, the embolization is started within the target vessel, distal to the side branch. And as a coil mass is being created within the parent vessel, you can use soft coils to push against that coil mass, which makes it possible for them to fold into the side branch, like in this particular picture. And what you eventually see is, now that you've embolized that side branch, you can continue with your coil mass in the parent vessel and get an occlusion of both the side branch and the parent vessel. No matter what technique you're using, it's always best to pack coils together as tightly as possible in order to achieve the greatest packing density. This may be facilitated with the use of non-fibered coils as opposed to fibered coils and hydrogel-coated coils. And this is a nice image from a recent article which shows the difference between these coils. A non-fibered coil is actually the bottom image, and you can see how well it packs within the lumen of this glass vessel. And then you have a hydrogel coil in the middle and a fibered coil up top, and you can see the spaces that exist between the loops of the coil. The ability to achieve a high packing density is likely associated with lower rates of recanalization. And as I mentioned before, this is because the arterial occlusion that occurs is based on the space-occupying nature of the coils and not on the formation of thrombus. Remember that coils relying on thrombus formation tend to be associated with higher rates of recanalization than other coils. So there's a lot to think about when trying to figure out what coil to select for a given procedure. So here's just a couple of things to think about. First off, pushable coils are much less expensive than detachable coils, but detachable coils are associated with greater control and are therefore safer to use than pushable coils, especially if you're working in a teaching institution. You also have to think about what the margin of error is at that particular moment, and that's how I select coils. I don't go into a case thinking I'm going to use one coil for the entire case. I select my coil based on the margin of error at that moment. One of the things I look at is the potential for catheter kickout. In this case, a catheter is pushed out of the vessel being embolized while the coil is being deployed. This can occur for many reasons. First off, the coil may be too large for the vessel. There may be poor catheter purchase or position within the target vessel. The coil selected for embolization may be too stiff or too long, and the catheter used for embolization may just be too soft. This is a nice set of images from Brian Funaki from a guest meeting a couple of years ago. You can see during this diagrammatic case of a GDA embolization. In the first image, you see a detachable coil being deployed pretty nicely within the GDA, but as the coil gets fully deployed, it tends to buckle out the catheter, and then all of a sudden, once the coil is deployed, your catheter is back in the hepatic artery and part of the coil is sticking out. So you need to be aware of the potential for this situation because it may warrant consideration of detachable coil use. So again, I look at each moment in an embolization procedure and figure out which coil is most appropriate at that time. When there's a low probability of error, it may be reasonable to use a pushable coil. But when there's a high probability of error, you can think about using a detachable coil, such as in a high flow vessel, maybe you have a tenuous catheter position, or you recognize the potential for catheter kickout. Now, as I've mentioned a few times already, acute occlusion during coil embolization occurs due to thrombus formation, or the space-occupying nature of the coil mass, and that depends on the type of coil used. On a long-term basis, occlusion persists due to chronic inflammation and the formation of fibrous tissue. We also know that recanalization is a possibility, and it can occur with all available coils. From a technical perspective, it can relate to packing density, and over time, recanalization can occur if there's coil compaction or lysis of thrombus. So before I end this lecture, I just want to go through some of the commonly available coils and talk about some of their distinguishing features. When it comes to pushable coils, you're probably using either Cook coils or Boston Scientific coils. The Boston Scientific coils are platinum coils with polyester fibers, and they're available as 018 and 035 coils. Cook has several types of pushable coils, including the Nestor coils, Tornado coils, and the MRI coils. The Nestor and Tornado coils are platinum coils with nylon fibers. The MRI coils are made of a nickel-chromium alloy with nylon fibers, and these are only available as 035 coils. There are several different detachable coils available right now. The first is the Interlock system from Boston Scientific. These are platinum tungsten alloy coils with Dacron fibers, and they are available in 018 and 035 configurations in several tertiary shapes. The soft version, the Interlock Soft, contains a thinner platinum wire and no fibers, and they're available only in the 018 size. And no handles required for detachment, but as you can see on the image to the right, what happens is this coil has an interlocking arm with its pusher wire, and once that point of intersection is out of the microcatheter, the coil is deployed. As long as it's within the microcatheter, you can pull it all the way back in and reposition it. The Concerto coil is a platinum coil with nylon or PGLA fibers, and the fiber type depends on the size and configuration of the coil. For example, the 3D version only has PGLA fibers. This is available as an 018 coil in either a standard or a 3D configuration, and a handle is required for detachment. The Ruby coil is a complex non-fibered coil consisting of a platinum tungsten alloy, nitinol, a gold tin alloy, PET, and titanium. They have a larger diameter of 020 and are therefore deployed through a larger ID microcatheter, and a handle is required for detachment. Penumbra also makes the pod device, which is a complex non-fibered system, again consisting of a platinum tungsten alloy, PET, and titanium. It's also available as an 020 coil. The important thing about the pod is that there's variable stiffness along the length of the coil. The initial loops are stiffer than the rest of the coil, which allows for packing behind those initial anchor segments of the coil, and a handle is required for detachment. Cook makes the Retracta coil, which is essentially a Nestor coil affixed to a pusher wire. It's the same platinum coil with nylon fibers, and it's available as an 035 coil. No handle is required for detachment. Instead, it's a screw-like detachment between the pusher and the coil. And finally, you have the Terumo coils. There's the Azure coil, which is available as an 018 and an 035 coil. The 018 coils are made of a platinum tungsten alloy, while the 035 coils are made of a platinum iridium alloy. And a larger ID microcatheter is usually used for the 018 coils. The hydrogel is a hydrophilic acrylic copolymer, which is a cross-linked copolymer of polyethylene glycol, diacrylamide, and acrylic acid. It's found outside of the coil, and these coils require a handle for an electrolytic detachment. The newest version of the Terumo coil is the Azure CX. This is available in 018 and 035 sizes. The 018 coils are made of a platinum tungsten alloy, and the 035 coils, ranging in diameter from 4 to 8 millimeters, are made of the tungsten alloy, but the 10 to 20 millimeter coils are made of a platinum iridium alloy. These coils have an inner hydrogel core instead of the outer hydrogel like the Azure. And these coils also require a handle for an electrolytic detachment. So I think that it's important to say that most of the available coils. In conclusion, coils represent some of the most basic and complex tools for the interventional radiologist to use during embolization procedures. This technology continues to evolve. It's always best to understand the nuances of each product so you can take advantage of their strengths and avoid their weaknesses. Coils can be used successfully for just about every case. I want to reiterate that I tend to try and identify the need and concerns of every point of an embolization procedure and then use the product which can best meet that need. The needs at the beginning of a case are certainly different than those at the middle and the end of the case, and as a result, it's common for me to use a few different types of coils in each case.